So the current guidelines for a small bowel obstruction are to advance fiber, so starting with less than 10 grams to 15 grams a day and advancing to a tolerated amount. This used to be called a low residue diet. They also recommend snacks every 3 to 4 hours or small meals, and to avoid spicy, acidic, fried, greasy foods and caffeine. And parenteral nutrition should be considered if the patient is not able to advance within 7 to 10 days. The guidelines for a partial or a hemicolectomy. A study documented 104 patients that were able to participate that had colorectal surgery over a 2-year period. 89 of those patients were advanced to an oral diet within post-op day 1 or 2, and 65 of them were able to tolerate the early feeding. So the study concluded that the early oral feeding is safe and possible for post-colectomy patients that have a history of colorectal cancer. Another study was a meta-analysis, and it concluded that early enteral nutrition after GI surgery does decrease mortality and hospital stays, although it does remain a controversial practice. Another study was the first study conducted in 1979, and it focused on the jejunal feedings within the first 24 hours of surgery, and it reported that the patients were able to tolerate the tube feed and it decreased hospital stay, but it hasn't been able to be duplicated since then. Additional guidelines for the partial or hemicolectomy: if a patient has protein calorie malnutrition, high calorie, high protein diet is recommended. Additional calories in the immediate post-op period are recommended for healing, but not all patients are able to tolerate enough volume to meet those needs. If, again, patients are not able to advance within 7 to 10 days, parenteral nutrition should be considered. Calorie needs after the patient has healed all the way, they are able to return to their normal diet, so no additional calories are recommended. And again, low fiber, just progressing as tolerated. Fluids should be higher, so additional fluids are recommended, about 35 mLs per kilogram per day. So this is something I just wanted to touch on, the current recommendations for diabetes in the older population. They don't recommend that you restrict an elderly patient's diet if their glucose is elevated. Rather, they recommend that you control their glucose levels by adjusting their medications. One study of 98 nursing home residents did a 3-day study where they rated the residents' diet based on variety. So they had a point system where they assigned points for wider variety within the diet. Their nutrition and health status was assessed by measuring their intake, their body composition, and different lab values. They found that those who consumed a higher variety had consumed the most calories, and those who received assistance while eating also had consumed a higher amount of calories. The residents with a history of GI cancer and other cancers had some of the lowest scores. So the study basically concluded that a highly varied diet in elderly nursing home residents is associated with better nutritional status. The impact of the nutrition care plan was basically a twofold nutrition care plan. For the first admission for the small bowel obstruction, the patient was on a clear liquid diet, so we were able to provide oral nutrition supplements. We did an interview and assessment with the patient, and then we also provided education regarding fiber and fluid intake. Our PES at that time was inadequate oral intake related to decreased ability to consume adequate oral energy due to small bowel obstruction, as evidenced by intake less than 25% of most meals, current full liquid diet orders, and patient report of poor oral intake prior to admission. Our intervention was to provide education regarding fiber and fluids, and then we wanted to monitor his intake. We wanted to make sure that he was consuming at least 50% of all meals, and that his glucose was staying less than 180. During the second admission, we didn't actually receive an initial consult. We saw the patient based on a positive screen. We did several assessments without an intervention, but eventually we did provide an oral nutrition supplement. After his surgery, we participated in ICU rounds and we monitored his PO status. And then when cleared by surgery, his diet was advanced and he saw the speech-language therapist. So his PES statement upon discharge was inadequate oral intake related to physiologic condition, preventing adequate oral nutrition due to recent partial colectomy, as evidenced by clear liquid diet orders and no oral intake for the past 3 days. For his intervention, we provided a commercial beverage, so we provided an oral nutrition supplement to aid in the healing process after his colectomy. And again, we wanted his intake to remain over 50% for all meals, with his glucose remaining less than 180. So when he was advanced to regular foods by surgery, basically internal medicine ordered the carb control diet, and then we didn't have the opportunity to meet with the patient again. Our impact on his nutrition care was really diminished at times due to poor communication of other healthcare team members, which is not typical. Typically there's really good communication, but in this case there was pretty poor communication. The hospital does follow traditional guidelines in feeding patients after a GI surgery. They wait for a bowel movement prior to starting feeding again. After his surgery, he was extremely groggy, requiring speech-language therapy intervention, which did slow down his progress. Collaboration between the internal medicine physician and the dietitian could improve, especially when the nutrition recommendations are questionable, like the fiber intake after a small bowel obstruction or the colectomy, and as well as restricting the diet of elderly patients when their glucose is elevated if they're at risk for malnutrition or have had a previous poor intake. A possible solution would be giving a referral to the dietitian if the physician thinks that they're unsure, or nursing could place the order for the referral as well. However, upon speaking with my preceptor, that's not necessarily possible. Unfortunately, she just thinks that they're going to have to continue correcting the diet orders. In conclusion, a small bowel obstruction and a partial or hemicolectomy are both very serious illnesses that can result in various complications or even death. So following the nutrition guidelines and providing the nutrition intervention is really, really important for these patients. It really encourages positive outcomes. So good communication is really important as well. It's really key to encouraging those positive outcomes and the success of the surgery and the patient's recovery.